Hello everyone, welcome to Medivice. In this video, we will be looking at a few must-know questions for the upcoming FMGE. So let's start with the first question. A 56-year-old multiparous woman presents with grade 2/3 uterine prolapse and a cystocele. She reports involuntary urine leakage when she coughs or sneezes. What is the most likely diagnosis for her urinary incontinence? Is it overflow incontinence, urge incontinence, stress incontinence, or neurogenic bladder? So to answer this question, we have to look at each and every option. So the correct answer to this question is stress incontinence, but we will also see what are the other options exactly. So stress incontinence is seen when there is involuntary and sudden loss of urine. This is seen in conditions where the abdominal pressure is increased. And examples of such conditions includes laughing, sneezing, coughing, and even during exercise. So in all of these conditions, when the pressure in the abdomen increases, this pressure is also exerted on the bladder, due to which there is leakage of the urine. We also had overflow incontinence in our options. So what is this? So this is where there is involuntary leakage of urine from an over-distended bladder. So basically in the bladder a lot of urine accumulates, after which there is release of small amount of urine. This is overflow incontinence. We also have urge incontinence, where there is an involuntary contraction of the muscles of the bladder. Whenever this contraction takes place, there is a sudden and very intense need to pass the urine. Finally, we have neurogenic incontinence, where there is some problems in the nervous system. It can be in the spinal cord, it also can be in the nerves. This is seen in conditions like spinal cord injury, multiple sclerosis, and stroke. So the symptoms may present as urinary retention or the opposite, where the frequency of urination may increase, and other problems. So coming back to our question, here the keyword was involuntary urine leakage when she coughs or sneezes. So since the urine is leaking when the pressure is being increased, so our correct option is stress incontinence. Next question. Which serotype of HPV is commonly associated with cervical cancer? So you can pause the video and try to answer this question yourself, and we'll have a look at the main points of cervical cancer. So it is the most common gynecological cancer in India, and the human papilloma virus is responsible for almost all of the cervical cancers. The site which is most affected in the cervix is the transformation zone. Transformation zone is the junction between the squamous cells and the columnar cells. This site is the most susceptible to catching this infection and causing cancer. And whenever in the question you read post-coital bleeding, foul-smelling discharge, very importantly post-menopausal bleeding or uremic symptoms, think of cervical cancer. And finally, the answer to our question, the types which are most associated with cervical cancer are 16, 18, 31 and 33. And so going back, our correct option is option D. Next, a 27-year-old woman presents with a 1-week history of malodorous vaginal discharge. Physical examination reveals a positive whiff test and a gram stain identifies clue cells. What is the standard treatment for this condition? Metronidazole, IV immunoglobulin, erythromycin or azithromycin? So to answer this question, first of all you need to know what is the diagnosis. So here the patient is suffering from bacterial vaginosis. This is most commonly caused by Gardnerella vaginosis, and we use Amsel's criteria for the diagnosis. So a straightforward question can come as Amsel's criteria is used for, and the answer to that will be bacterial vaginosis. So in this condition, we see creamy discharge, whiff test is positive, fishy odor and clue cells. Clue cells are vaginal cells which have a lot of bacteria embedded in it. And if any 3 out of these 4 are present, then we say that the person has bacterial vaginosis. Very importantly, no pruritus is seen, and the treatment which is given is metronidazole. Importantly, this is only given to the woman and not the partner. So coming back, our correct option is option A. What dosage of folic acid is recommended for a woman planning to conceive who has a history of pregnancy complicated by a neural tube defect? 400 micrograms per day, 1 milligram per day, 2 milligrams per day, or 4 milligrams per day. So folic acid is very important for women who are pregnant, which leads to a decrease in the neural tube defects. So for prophylaxis, this folic acid is given before the conception takes place. And there can be two cases. If the previous pregnancy was normal, we only give 400 micrograms per day. But imagine if there was a previous pregnancy where the baby was suffering from a neural tube defect, then we give 10 times this dose, meaning 4000 micrograms per day. So coming back to our question, here the correct option is option D, which is 4 milligrams per day or 4000 micrograms per day. Next. Marsupialization is the preferred treatment for a specific condition involving the female reproductive tract. Where is the lesion responsible for this condition typically located? Perineal body, Bartholin gland, uterus, or vagina? So what exactly is marsupialization? So it is a surgical procedure which is done for Bartholin cysts. Bartholin gland, as you know, the main function is to secrete mucus and providing vulvar and vaginal lubrication. So what do we do in this procedure? The cyst is incised and all of the liquid which is inside the cyst is drained, and then the edges of this cyst is stitched to the surrounding vaginal wall. This way there is a permanent drainage pathway created. So coming back to our question, our correct option is option B or Bartholin gland. Next, which of the following statements is incorrect regarding vasectomy? The procedure is done under local anesthesia. Sterility is achieved 3 weeks after the procedure. A no scalpel technique is being widely used now, or the vas deferens is divided in the procedure. So pay attention, the incorrect option is being asked. So let's see a few important points about vasectomy. So this is a permanent method of contraception and is performed under local anesthesia. The part which is divided is the vas deferens, and there can be two approaches. Conventional vasectomy, where there is a small incision in the scrotum and then the vas deferens is divided, or a non-scalpel technique where there is a puncture. Very important to note that sterility is not achieved immediately. The person still has to wait about 3 months. So coming back to our question, the wrong statement here is option B, because sterility is not achieved in 3 weeks, but it takes about 3 months. Next question, which intrauterine contraceptive device has the longest lifespan? Progestasert, Copper T380, Mirena, or Nova T? So let us look at a few important lifespans which they may ask. So Nova T has a lifespan of about 5 years, Copper T380 is 10 years, Progestasert 1 year, and Mirena about 8 years. So here you can see the longest lifespan is in Copper T380. So going back, our correct option is option B. Now our final question. A 28-year-old woman presents with infertility, dysmenorrhea, and pelvic pain. She has a history of recurrent pelvic inflammatory disease. A hysterosalpingogram reveals no peritoneal spillage on the right side. What is the most likely diagnosis for her condition? Tubal block, endometriosis, Asherman syndrome, or hydrosalpinx? So the correct option to this answer is actually tubal block. So hysterosalpingography is a procedure where we do X-ray with the help of contrast dye. And whenever there is tubal block, this dye is not able to go beyond this block, and we will be able to visualize this in the X-ray. So on the right side, you can very clearly see that the uterus, the fallopian tubes, all are perfectly visualized. But this tubal block is seen in conditions like chlamydia infection, pelvic inflammatory disease, endometriosis, and extensive pelvic surgery. So if there is a tubal block, this is how it is going to look like. The dye will not be able to go past this obstruction, and so we will be able to see this in the X-ray. So going back to our question, you can see that the question says that there is no peritoneal spillage on the right side, meaning the dye did not go through the fallopian tube. And also this patient has a history of recurrent pelvic inflammatory disease. So all of these point towards a diagnosis of tubal block. That's it for this video. If you have any doubts, so please leave them in the comments or feel free to message on Instagram anytime. I will be leaving the link to my Instagram in the description. Thank you.